So thank you so much for inviting me to speak tonight, and it's really nice to be here and to have so many people watching on. Tonight I'm just going to give a little bit of a talk about foals in the intensive care unit. Often when foals are admitted to the ICU, it can be stressful for both the owners and the breeders, and is often associated with considerable emotional and financial commitment. And it can be hard to know exactly what to expect from this experience. So I thought I would talk through, firstly, when your foal should be presented to the ICU, and the general procedure and setup of foals within the intensive care unit. And maybe at the end we can discuss some common syndromes and diagnoses that we might see in foals in the ICU. So before we can really determine when things are going wrong, we first have to know what to expect from a normal foal. I'm sure most of you have witnessed normal foalings and have been around normal foals enough to sort of be able to determine that. But I thought I'd just quickly touch on it. The general thing that we look at is the 1, 2, 3 rule. So 1 hour after parturition, the foal should be standing. After 2 hours, it should be nursing from the foal. And after 3 hours, the mare should have passed her placenta. The placenta should look visually normal and be less than 11% of the weight of the foal. If your foal isn't standing and nursing within 3 hours, it really needs veterinary attention and intervention. And the beauty of knowing these rules is knowing when things are going to go, when things aren't going right, essentially. I also just wanted to point out on this slide as well that foals that are born with mares that have had dystocia, that we should be monitoring those foals more carefully. And also, even if foals are born and they look normal and they achieve their milestones within the set amount of time, we should be monitoring them closely for the first 24 hours of life. These foals can look normal and then can deteriorate quite quickly within the first 24 hours. So I've just put up some normal foal parameters here. I wouldn't necessarily expect people to be recording things like heart rate and temperature in foals that are looking normal and achieving normal milestones, but sometimes I think it's good to know normal parameters. So in situations where you are worried about your foal, or the foal isn't standing and nursing within 1 to 2 hours, you can take heart rates and temperatures and know what normal is and know when you should be a little bit more concerned. So the other thing to note is to know if your foal has urinated and when your foal has urinated. I've said here that the first urination is usually within 24 hours, but in reality, a healthy foal will probably urinate a lot earlier than that, and generally within 4 to 6 hours, I would expect. But if your foal isn't or hasn't urinated within 24 hours, then we really know that something is going wrong, and we need to be able to examine that foal, and it probably needs to be seen by a vet. Passing meconium is another one of those really important milestones that I'm sure everyone monitors really, really closely. I also like to monitor for the normal milk feces to come through as well, because then we can be a little bit more confident that the entirety of the meconium has been passed. Again, I've said 12 to 24 hours or within 12 to 24 hours, meconium should be passed, but in a healthy foal, you'll probably see it a lot sooner. But if you haven't seen it by 12 to 24 hours, then perhaps there's something else going on with this foal, and that's why it hasn't passed its meconium. I would also say that sometimes people like to intervene early with these things and administer enemas, and that's fine, but repeated enema administration really should be avoided, particularly if you're not seeing meconium after your enema administration. And if that is happening, then there's probably a reason why your foal isn't passing meconium, and there's probably some other underlying condition that we need to assess. So most importantly, I think, is a foal that's not nursing is a sick foal. And sometimes it's really easy to give foals that are standing and that look bright and look quite healthy an excuse not to be nursing well. And a foal that isn't nursing or isn't nursing as often as it should be is probably a sick foal. The suckle reflex or nursing is a really coordinated movement that involves creating a tongue seal over the teat and sucking and swallowing. And often when they're not doing well, or there's slight neurological abnormalities or something else going on under the surface, the suckle reflex is the first thing that we see to deteriorate. So the sooner we can observe that, the quicker we can kind of the quicker we can kind of intervene. So I've got two examples of foals that have been standing and look really bright and alert, but aren't nursing effectively. This little foal here on the left has got milk dripping from its nostrils after nursing from the mare. And this happens when they're not creating a really good tongue seal and when they're not swallowing, and then you get milk building up at the back of the throat, and when they move away from the udder, then milk pours out of the nostrils. There are other reasons why this might happen, such as cleft palate abnormalities, but by far the most common reason is because your foal is not nursing effectively. This little video here is just showing a foal at the udder. I think if you were standing away or at the box of this foal, you might be fooled into thinking that it is latching on, when in actual fact it's a long way from it. It's a really abnormal tongue movement, and it's not going anywhere near the teat at all. And in both situations, I think monitoring these foals from a distance, it would be really easy to miss the subtle signs that these foals aren't nursing properly. And when they're not nursing properly, they are prone to secondary complications, such as aspirating milk onto their lungs and developing a secondary pneumonia. Also, when they're not nursing effectively, they're obviously not getting as much milk as they need, and that's when they become quite dehydrated, their blood glucose levels drop, and then they get a lot sicker than they already are. So there are many other reasons why you might present your foal to the ICU. It might be an unwillingness or a reluctance to stand, or a complete inability to stand and hold its own body weight. A colicking foal, a foal that's starting to defecate, a premature foal. Even if they do look normal initially, I think that these should be monitored and probably assessed by a vet regardless. And a foal with diarrhea, I think that's a really common one. I also just wanted to point out these two little foals here. They're foals that are systemically healthy and behaviourally normal, but they have severe musculoskeletal abnormalities. So this little guy on the left here is severe flexural contraction of both front limbs, and this is the little windswept foal here. And these musculoskeletal abnormalities have been prohibiting these foals to stand without assistance. And when they can't stand, they can't nurse, and then they can't maintain their own hydration, and they're not getting the nutrients and glucose that they need, and they deteriorate quite quickly. Even though they are normal foals, they're still really susceptible to dehydration. And so these foals probably should be assessed by the ICU as well, and probably admitted to hospital. They require quite a lot of labour and quite a lot of monitoring. So you've identified an abnormal foal and you want to bring it to the ICU. What are the first kind of steps? The first step is generally to collect a really thorough history, and these are some of the questions that we may ask you when you want to bring your foal into hospital. And generally we're mainly aiming to understand if there was anything that happened during pregnancy or during parturition, during birth, that may have negatively impacted your foal. And this may include placentitis, it may include dystocia, anything like that. Some foals can be immediately normal immediately after birth, and then deteriorate within the initial 24 hours. And this is important information to collect as well. And we also need to know how the foal's been managed on farm in the postpartum period, if any treatments have been administered. And all of this history taking helps us get ready for your foal's arrival and start to formulate some ideas and hypotheses as to what might be happening. It will also help us to guide you through managing future foals on your stud or on your farm in the same breeding season, and maybe future foals from that broodmare in future breeding seasons. This history-taking step generally happens before the foal even gets to hospital. It generally happens over the phone, and that is because when the foal arrives, it can be a little bit hectic, it can be a little bit daunting and overwhelming. So this photo here shows 7 people examining one tiny little foal in the corner. So we have nurses, we have interns, we have specialists all examining the foal. It's not always this hectic, but generally there is more than one person waiting for you when you arrive with your foal. And if there's several vets involved, then the process moves quite quickly. And so it's nice to have the history before you even arrive. So when your foal arrives at the ICU, we start examining your foal pretty much straight away. It starts from a distance. So is the foal standing? Can it move? Does it have good affinity with the mare? Is it following the mare? Does it know where she is, or does it not really care? And then we do a really thorough physical examination. We look at conformation, not only of the limbs and the joints, but also of eyes and mouth. We examine mucous membranes, and then we listen really carefully to heart sounds, lung sounds, gastrointestinal sounds. We might examine the umbilicus. And then we take blood. We can assess hydration. We can assess blood glucose concentration, electrolyte balances. Depending on the age of your foal, we may or may not measure IgG at the time of admission. Generally, we do wait until 24 hours, and particularly if the foal hasn't nursed, then we know that it's going to have a really low IgG. And so it's kind of something that we often miss in that initial step, and then we follow up on later on in the treatment course. We'll also collect blood for full blood examinations, so hematology, blood biochemistry, looking at red cells and white blood cell counts, fibrinogen, serum amyloid A, liver enzymes, kidney enzymes, and we'll also take a blood sample for a bacterial culture. And this is kind of an important step initially. We like to do that before antimicrobials have been administered. Depending on what we find on these examinations, we may want to move straight to further diagnostic tests. So we might want to scan the chest or scan the abdomen. We might want to take radiographs. And essentially, we're trying to put together a really good, thorough picture to assess the severity of what's going on and the amount of intervention that's initially required in this foal. So once we've examined the foal, then we need to set it up so we can treat it. Can always look a little bit hectic with a lot going on with these little guys when we initially set them up, but essentially what happens is we put an IV catheter in, and that's what's under this neck bandage here. We generally use these over-the-wire catheters. They're quite long catheters, they're really soft, and when they're maintained well, they can stay in place for a really long period of time, which is quite handy. We often have a double access to the one catheter, which is really nice, so we can give IV fluids through one and then still give IV treatments like antibiotics or whatever the foal needs through the other, or have multiple fluid lines set up if the foal is really intensive and needs to be on glucose or needs to be on constant blood pressure medication, and it's nice to have dual access. And then we have a little nose bandage here holding onto two tubes. One is an oxygen tube. A lot of these foals, particularly the foals that can't stand, will need to be on intranasal oxygen. And then we have a feeding tube in the other side. So an indwelling nasogastric tube that sits in the stomach, comes out the nostril and sutured in place. And we kind of keep that in place for a long period of time. So that's really handy. I kind of live the rule of that a foal that can't nurse from the mare is a foal that can't nurse from the bottle. And rarely do I use bottles in foals at all. If a foal can't stand, then it certainly can't nurse, and a foal that can't nurse from the mare can't maintain a good enough suckle reflex to be able to nurse from a bottle. And bottles release milk a lot more readily than the udder, so the risk of aspiration onto the lungs and secondary pneumonia is a lot higher. The nasogastric tubes, when they're in place and they're sutured in place, they're really nice and really easy to be able to control the amount of milk that the foal's getting, and it's a really safe way of being able to do it. So we're aiming to treat the problems that we see, but also prevent further complications and involvement of other body systems. So early intervention is really essential in that, and foals that deteriorate quickly do get involvement of other body systems, and we might see that in terms of septic joints, we might see that in terms of renal failure. So early treatment and prevention of these complications is essential. And really, overall, there is no one-size-fits-all treatment plan in these foals. We tailor each treatment to the foal and adjust it constantly depending on how the foal's responding to treatment. So some common treatment considerations, intranasal oxygen therapy, and we can determine if a foal needs that based on oxygen saturation of the blood. And that is something that we measure quite frequently in these foals, but generally foals that are recumbent and can't stand will require oxygen therapy. Intravenous fluid therapy, I think most of us think, sick foals need fluids, and most of the time that is right. But our type of fluid is going to change depending on whether we're treating for dehydration or whether we're just maintaining hydration, what the electrolyte balances of these foals are. Do they need extra sodium? Do they need extra potassium? And again, this is something that we're constantly evaluating and constantly changing based on the needs of the foal. Glucose, as we've already mentioned, quite a lot of these foals aren't nursing effectively or aren't nursing at all, and therefore they're not getting the energy that they need. Foals have really poor energy reserves, and so we need to be able to supplement that. And a nice way of doing that is with intravenous glucose, and we generally do that alongside our fluid therapy. Systemic antibiotics, lots and lots of foals, or most foals that come into the ICU will be administered antimicrobials, and I'll touch on sepsis a little bit later. Milk feeds, depending on the foal, we will start milk feeds early. We generally start with really low volumes and then gradually increase the volume that we administer. Some of these quite sick foals don't tolerate a lot of milk, so their gastrointestinal tracts are really dysfunctional and are moving really slowly, and so they can't handle large volumes too frequently. And so we can monitor that by looking at the foal after we've fed it. If it's colicking, if we see any reflux before we feed, then we'll back off. But as a general rule, we usually start with small volumes and then generally increase to 10% of the foal's body weight, but hopefully by the time it's getting that much milk through the nasogastric tube, it's nearly ready to nurse from the mare on its own. And then other things that we consider based on individual cases is whether the foal's seizuring and we need seizure control, whether the foal needs a plasma transfusion at some point during its hospitalization, whether it can maintain its own blood pressure. Some of these really sick foals can't maintain blood pressure and have low blood pressure, so we need to consider that. And then some of these foals aren't breathing that well either, and so we need to consider that in our treatment plans. And so I thought I'd just talk through the different ways that we can set up foals in the ICU and the way that we can tailor our treatment according to where the foal's at and how sick the foal is. So here we have 3 foals. They can all stand on their own without assistance. They can all move about without assistance. This little guy here in the middle, he can actually nurse from the mare, but he's still a bit dehydrated and his electrolytes are a little bit out, and so he still needs intermittent intravenous fluid therapy. So we let him in with the mare. He can nurse on his own, supervised, and then he comes back and he goes back on his intravenous fluid therapy. This little guy up here on the left is a foal. It's got really good hydration, normal electrolytes, but is still nursing ineffectively and inappropriately. So we can give it most of its daily requirements of mare's milk through the nasogastric tube here. And then it's got a little muzzle on, so it can't nurse without us watching it. And then we can monitor how it's nursing and gradually allow it more and more time with the mare as it begins to be able to nurse more effectively. And then this little foal here is quite sick. It's still on intranasal oxygen. We're still, it's not nursing at all. We're still giving it milk through the nasogastric tube, and it's still hooked up to fluids. And it's in its own little section of the mare's box. So the mare and the foal can still see each other and touch each other and smell each other and develop that really important mare-foal bond. But the foal has its own space so that we can still treat it and it can still move around as it wants. And then we have more sick foals. So this foal here in the left is a foal that can probably stand up with assistance, but is still dull most of the time. Most importantly, it can sit up by itself. It doesn't need any help with that. It's still on oxygen. It's still on fluids. And so we go in with it. We encourage it to stand every few hours. We lie it down on the other side. These little guys here are probably what we most typically recognize as our bed babies. They're really quite sick foals. They're variably responsive to stimulation. They cannot sit up on their own, and so they're in these sternal supports to keep them sitting upright, which is super important. Too much time lying on one side does impact their ability to breathe and ventilate properly, so sitting them up is super important. And these foals are on intravenous fluid therapy, they're on IV glucose therapy, intranasal oxygen, they're getting small amounts of milk through their feeding tube, and we're going in there super frequently and turning them and making sure that they stay dry and there's no pressure sores occurring. And so, but this is just the start of the hospitalisation. So we've got these foals in, we've set them up, we've tailored our treatment, our initial treatment plan to what they need, and then it really all starts. So then we monitor these foals so carefully and so frequently, and we monitor so many different things. We monitor the obvious things like heart rate, temperature, respiratory rate and effort, behaviour responses, demeanour and mentation, and these things are kind of measured constantly throughout the day really, and recorded every few hours. And being able to see trends in temperature and heart rate help us determine how well the foal's going. And then things like blood oxygenation saturation, or blood lactate, blood glucose concentrations, blood pressure and urine concentration are measured maybe 3 times a day initially in the really sick foals, and then we sort of back off to twice or once a day as our foals start to improve. And then things like hematology and blood biochemistry that we took initially, we may repeat that every 24 to 48 hours, depending on how concerned we are on our foals. Like I mentioned before, IgG concentration, we might measure that at 24 hours of age. Like I said, these foals are variably fed mare's milk and colostrum, and so they quite often have failure of passive transfer of immunoglobulins and require a plasma transfusion, after which we'll remeasure IgG. And blood culture, if our foal isn't going so well, we may want to repeat our blood culture. So that's essentially what happens when a foal comes in and is sick. And I thought now we could just briefly talk about some of the really common clinical conditions that we might see in foals that come into the ICU. These top 3, so a premature or dysmature foal, a dummy foal or neonatal maladjustment syndrome foal, and a septic foal are probably the most common, and everybody's probably heard of those before. And they all present really, really similarly, and they're not really exclusive. So foals that are a dummy foal can also have sepsis, and a premature foal can also have sepsis. The severity of disease in these foals are also on a spectrum. So you can have foals that are really mildly affected and have foals that are really severely affected. And these are kind of examples of that. So you can have a foal here on the right, it's bright and happy, can stand without assistance, but it's still really behaviourally abnormal. It's still trying to nurse on the wall intermittently and has a really abnormal tongue position. There's no way that this foal could nurse from the mare effectively or appropriately. And then you have a foal here, it's really dull, it needs assistance to stand, it needs assistance to maintain a standing position. Again, it's got an abnormal tongue posture. And so these are probably more mildly affected foals, and then you can have the really severely affected foals and the seizuring foals. So this foal here is seizuring. This foal here is seizuring, as you can see. Well, I mean, they all look a little bit different. I'd say seizure. Some of them are more obvious than others. And foals can seizure for multiple reasons. They can seizure from sepsis and having infection in the CSF fluid, so the fluid that surrounds the spinal cord and the brain, or they can seizure because of a neurological abnormality associated being with a dummy foal, low glucose concentrations, electrolyte derangements. And so we can have foals on a whole spectrum of clinical severity. So what kind of separates these 3 clinical conditions from each other? A premature foal is a foal that's born at less than 320 days of gestation, and they look different. So This is a typical premature foal. It looks really small in relation to its mare, and they have a really fine, thin hair coat. And you can see along the back here and along the legs here, this foal is almost hairless in places. They have a really odd shaped head, so they have a really domed head and funny little pixie ears, and often their head size is a little bit disproportionate to their body. And a dismature foal is a foal that looks like a premature foal, but it has a gestation length of greater than 320 days. And that's the only real difference between prematurity and dismaturity, is gestation length. In both situations, it's really important to assess joints. And I kind of put this radiograph in here just to kind of prove a point, I guess, but in these foals, it's really important to assess these joints and to assess them really early on in the treatment process, because it may impact the way we treat these foals, or if we even attempt to treat these foals. So this little foal that I showed you on the slide before, this is its radiographs of its knee, and this is a normal foal's knee. And you can see that this foal really has really immature bone formation. And this is going to have really lifelong negative implications of this foal's ability to perform as an athlete in any discipline. Neonatal multisystemic maladjustment syndrome, I think, is probably the most appropriate term for a dummy foal. A dummy foal we sort of typically associate with the behavioural abnormalities or of the slow foal. So this foal nursing at the wall, this foal sleeping, standing up, are kind of typical dummy foal behaviours. Dummy foals, what we can associate them with mares that have had a history of placentitis or dystocia or cesarean, but not always. Sometimes parturition is completely normal and the placenta looks normal in these foals. We often talk about the behavioural and the neurological abnormalities in dummy foals, but it's a multisystemic syndrome. So quite often we see issues with gastrointestinal function, like I talked about. Those gastrointestinal tracts don't move that well and can be really slow. And they can often have trouble maintaining their blood pressure, maintaining thermoregulation. And so there's a lot to monitor in these foals other than just behaviour. Sepsis. So we definitely sort of work around the mantra of all foals are septic until we can prove that they're not. And we do that through collection of blood for bacterial culture. And hopefully we can culture the bacteria that's causing the sepsis, obviously, or causing the blood bacterial infection. And then we can tailor our antibiotics to that particular organism. It's not always successful, and sometimes septic foals do have negative cultures, and so we have to look for other ways of determining sepsis, and we do that with our hematology. So our white blood cells, our serum amyloid A, fibrinogen, they all give us an indication if a foal is septic or not. There is some clinical signs of a foal being septic, or that might make us suspicious of a septic foal, and that includes inflammation within the eyes, really injected mucous membranes or sclera, and they might have really injected gums. They often have hyperemic coronary bands, and those foals we start to think maybe they have sepsis. And these septic foals cause us a lot of concern. We often stress about them a lot because they can have secondary complications associated with their sepsis. And the most common, or the most known, would be septic joints. And then that often has implications associated with future performance. But other things that we need to think about are pneumonia and their umbilicus. There are other sites where infection can kind of sit. Neonatal isoerythrolysis. I kind of put this in here. I'm sure lots of people have heard about NI foals. Not super common, but they do happen, and it's important to be able to identify when they are. So it's a condition whereby the mare develops antibodies to the foal's red blood cells and then passes those antibodies to the foal through the colostrum. The antibodies are absorbed through the gastrointestinal tract into the bloodstream, just like they should be. and then they go ahead and start to destroy the foal's red blood cells, and the foal becomes really, really anemic and turns this really jaundiced yellow colour that we can see in gums and we can see in the sclera or the white of the eye. So these foals usually present to the ICU a little bit later, generally 2 to 3 days of age. They can be really dull, they go off the suck, and they quite often require blood transfusion. They quite often require intranasal oxygen therapy, maybe intravenous fluid therapy as well. They respond variably to treatment. Some foals respond really, really well, and other foals don't, and that's due to a whole number of reasons, including the foal's blood type and how much colostrum it was administered. But this condition certainly has implications for breeding that mare in the future, and not that you shouldn't breed her, but you should be aware that she may have this problem with future foals. So prognosis, like I said at the start, there's often a lot of emotional and financial commitment when we admit foals to the ICU, and so it's always nice to know what the chances of survival are. So there was quite a nice little study done out of an American university in 2017 that looked at dummy foals with sepsis and with prematurity, and 80% of the foals survived to discharge. The foals that didn't survive were septic foals that had disseminated signs of sepsis, so had those secondary complications such as septic joints, pneumonia, umbilical infections. The non-surviving foals were also the more severe foals, so the foals that required more support to ventilate and breathe normally, that required more support to maintain normal blood pressure, and that required more support in terms of anti-seizure medications. And certainly this is my experience clinically as well. Foals that come in and don't require all the extra things often do quite well. Septic foals that below septic joints often do less well, but also response to treatment gives us such a clear idea of how foals are going to go and if they're going to survive to discharge. If foals respond really well to early intervention and start to improve straight away, then that's a really good sign. But if foals continue to deteriorate despite our efforts and despite all of our intervention, then we start to get really concerned. So my take-home messages, I thought, were that early intervention and treatment is really key to a successful outcome, and the sooner these foals can get to hospital, the better. Each foal is different and requires its own tailored treatment plan, and we really try to provide that within the ICU environment. And a lot of these foals, they've only got a certain number of ways that they can tell us that something's going wrong, and so our clinical signs overlap with our really common conditions. I could honestly talk for hours about sick foals, and I hope I was able to give you a really brief overview of the procedures that happen within the hospital environment with these sick little foals and the common clinical syndromes that we see, but I'm really sorry I couldn't cover it all tonight, so please feel free to ask me any questions.
Thank you, Jess. We can definitely hear your passion there for little foals and their treatment and what that looks like in the ICU. Now, we do have a few questions before we hit the home stretch and jump on to Peter. Now, Holly's asked if we can email your slideshow later on, so I'm sure we could organise that. So I've been asked here, what are your thoughts on using the squeeze technique on dummy foals?
Yeah, I think people have varied opinions on squeeze technique. It comes from the idea that dummy foals in particular, so it doesn't work on all clinical syndromes, and we're talking about the dummy foal syndrome here, that they haven't had the necessary hormone cascade that kind of wakes the foal up during parturition. And so if we squeeze them and we kind of repeat that parturition or that birthing procedure, that we stimulate that hormone cascade and those foals are going to wake up. I think it has really variable success, and I think that it's really difficult to perform properly. I don't think it does any harm, and I certainly know studs that do use it routinely in their dummy foals and give it a go, but it's not something that I generally implement within the hospital setting at all.
And we also have from Jessie, what is your fluid therapy protocol for a foal that is poorly nursing and dehydrated? The owner in this case can't afford ICU.
Yeah, I think it's really tricky. And you know, we do have to be really careful about the electrolyte composition of the fluids that we give our foals. Generally, a resus fluid we look to is Hartmann's, and that can be fine as your initial bolus, but long-term and repeated administration of Hartmann's, we have to be really careful about the amount of sodium that we're giving these foals. So, so it's fine when owners can't afford the ICU, but I mean, we have to recognise that it's less than ideal to be giving boluses and to be giving as much sodium as that is in Hartmann's. So yeah, I mean, I'm not sure I completely answered the question, but.
It's okay, we'll take one more here now from Kira. What is the future prognosis for a dummy foal as a riding horse or an athlete?
Yeah, I mean, if it's just a dummy foal and there's no signs of concurrent sepsis, then the prognosis is really good for these foals. So they do go on to be completely normal, neurologically sound, behaviourally normal foals and adults. It's all the secondary stuff that we worry about and try to prevent that stops them being athletes. So sepsis is the big one, and blowing septic joints or developing pneumonia and things like that. But dummy foals themselves without inflammatory response actually do really, really well.